Good evening, my name is Marco Valtierra, and today we're going to be doing an assessment of the thorax, respiratory, and cardiovascular system. To help us here is Carlos, he's going to be the patient. So when you're assessing the respiratory system, you want to start off by making sure you inspect and survey generally the chest, making sure the respiratory rate is normal, the depth of respirations is normal, making sure that the patient doesn't look in distress. For the next part of the assessment, we would do both the front and the back, and we want to palpate, make sure there is no tenderness, no crepitus, and no deformities. So in this case, he doesn't have any of that. Next, we're gonna do part of palpation still, chest expansion. So I'm gonna put my thumbs in the middle of his, on this midline right here, and ask him to take a deep breath. Okay, one more time. Okay, and so with that, we're checking symmetry, making sure both sides expanding the same. And also part of palpation, we're gonna be doing fremitus, and we're gonna do the bony prominence of our hand, and we're gonna feel the vibrations on his back. So for this, we ask the patient to say a word that is low pitch. In this case, it's gonna be 99. So Mr. Carlos, can you please repeat 99?
99, 99, 99.
So in his case, the fremitus is normal. The vibrations feel normal. For abnormalities, you would be looking at patients that have no vibrations, which means there is like air trapped in between the chest wall and the lung. For mass lesions, you would look at dull vibrations. For consolidation, you would feel increased vibrations, and for fluid, you would feel decreased vibrations. And for the next part of the assessment, it's called percussion, and we're gonna be doing this with the distal interphalangeal joint of our middle finger, non-dominant hand. We're gonna put it on his skin, on his back, and we're gonna, with the dominant hand on the same finger, we're gonna strike it with the tip. When you put it on his skin, make sure no other part of your hand is touching his body. So we're gonna start again at the bottom here. You wanna make sure you're doing this in between the rib spaces. And with this test, for normal patients, what we hear is called resonance, and that means that the lungs are filled with air. If you feel dullness, it could mean there is fluid, or that is some sort of solid consolidation. With free, if there's free air, it could indicate, or pneumothorax, I'm sorry, it would be hyperresonant. And for the next part of the assessment, we are actually gonna be moving on to the cardiovascular system. So we're gonna ask the patient to sit face the front, and we are going to first also inspect the chest, making sure, actually, can you lay down, sir? So when you're assessing the chest, you want to make sure you don't, general inspection, you're trying to see if you see the apical impulse, making sure there is no heaves, making sure there is no abnormal pulsations, and you want to also palpate Make sure that you don't feel any pulsations in anywhere. You palpate for the apical impulse, which should be around the left mid-clavicular line, fifth intercostal space. Okay, so I can feel it right here. It's normal. And for the next part of the assessment, we are going to put our hand right here on the sternum, and also making sure there's no heaves or thrills or anything like that. Before we do auscultation, now we're going to measure the jugular venous pressure. So we're going to have the patient turn his head to the left. We're going to be looking right here on the right side along the sternocleidomastoid muscle. We're making, once we notice a pulsation, we look at the meniscus, which is the highest part where you can see it. Next, you need an index card and a ruler. The ruler goes on the mid-sternal, the angle of Lewis, which is where the manubrium and the body of the sternum join together. So you would put the ruler horizontally, and again, you put the flashcard on the meniscus, and make sure you're using centimeters. So anything above 3 centimeters above the mid-sternal angle would be considered abnormal. In his case, it's like 2.8 centimeters. So now we're gonna do the auscultation part, and for that, we're gonna auscultate all the areas of the heart, aortic, which is the second intercostal space along the right sternal border, pulmonic, second intercostal space, left sternal border, Erb's point, third intercostal space, left sternal border, tricuspid, fourth intercostal space, left sternal border, and mitral, which is mid-clavicular line on the left side, left side, mid-clavicular line, fifth intercostal space. So for this, we actually start at the bottom. We start at the base. When we're listening, we want to make sure we don't listen for we don't hear any murmurs, no abnormal heart sounds. Systolic murmurs are heard on when the heart contracts. Diastolic murmurs are heard when the heart relaxes. For S1, S3, you hear that right after the second heart sound, S2, and for S4, you hear it right before S1. So you want to make sure you pay close attention, you're listening for all those things. You listen first with the diaphragm of the stethoscope, then with the bell, because the bell can help you hear different types of sound, different pitches and stuff like that, so you can make sure you it helps you assess better like the murmurs, S3, S4, and things like that. So you want to make sure you use both. Okay, so I can hear S1, S2, there's no murmurs, no S3, no S4, no abnormalities of that kind. For the next part of the assessment, we are going to assess his internal carotids. First, try to see if you see any, you can see the pulsations. Obviously, you want to palpate, make sure there is no, you do this one side at a time, because if you do both sides, it can cause syncope. So right side first, then left side, and you want to feel for any thrills or any abnormalities like that. And now we are going to auscultate the carotid with the bell, and we are going to be listening for any bruits or any whooshing sounds. Very important, make sure the patient holds his breath so you don't hear the air coming in and mistake it for a bruit. So can you hold your breath real quick, sir? Okay, so no bruit. And can you please take a seat, sir? So when you do, going back to the respiratory system, I can't remember if I did the auscultation, so I'm gonna do it again. Can you please take a deep breath? 1 second. You wanna make sure you listen also on the sides, and make sure you listen to all the different lobes. On the right side, there's 3 lobes. On the left side, there's 2. We want to make sure we listen to all the areas, and we're looking for any abnormal lung sounds, any crackles, any wheezing, anything that would indicate the patient's having some sort of respiratory disease. Take deep breaths, please. Okay, and then can you turn around? We're going to do your back. Take deep breaths. We want to make sure we listen. It's called a step ladder method. So you listen to one side, then you go over to the other side, and then you go back to the other side, and that way you're comparing both sides, making sure that the lung sounds are the same on both sides. Deep breath. And another very important area to auscultate is the apices of the lungs right here. Sometimes if the patient has like a pulmonary embolism or a pneumothorax, you'll only be able to listen at the apices. So you want to make sure you get those areas too. Okay, so for him, everything is clear. Also, we need to assess voice transmission when we do auscultation of the lungs, and we want to make sure that normally, again, we ask the patient to say 99, and we shouldn't be able to hear any, it shouldn't be clear. If it's clear, it means there's something going on that in the lungs. So can you say 99?
99, 99, 99, 99.
Okay, so it sounds muffled, which means in this case, that's actually a good thing. So let me just make sure we went over everything. So yes, it appears that we went over everything, and that concludes our assessment. Thank you so much.